Welcome to the 2023 Edinburgh Parkinson's Lecture. My name is David Melton and I organise the lecture on behalf of the Edinburgh branch of Parkinson's UK. It's lovely to see so many people in person back at the Royal College of Physicians of Edinburgh. I wasn't completely accurate with my weather forecast prediction, but thank you for coming anyway. It's great to see you all. And we also have over 800 people have registered to watch online. Before we introduce this year's Edinburgh Parkinson's Lecturer, I'd just like to remind the people who are watching online that they can use the Slido box to ask questions of the speaker. We're particularly interested to get questions from people affected by Parkinson's. And if you want to ask a question, you don't need to put your name on, just put PWP in the name box. And that'll help my colleague Thilo Kunath, who'll be juggling online and live questions to select the questions that he thinks are most important. You can also vote for other people's questions if you're watching online. I'd now like to ask James Jopling, the Scotland Director for Parkinson's UK, to introduce this year's Edinburgh Parkinson's Lecturer. James.
Hello, everyone. Apart from the fear of someone saying there's 800 people online, as I stand here, which was not a number I was anticipating, I think it's only marginally better than hearing you're doing a talk and you're not wearing any trousers. So I'm relieved that at least I appear to be clothed, and it's delightful to be with you today. This is now my second Edinburgh Parkinson's lecture. I was here last year for Julie Jones's, and I'm looking forward greatly to this evening. It's my great pleasure to introduce the Parkinson's lecture this evening, and our esteemed guest to deliver it, Professor Camille Caroll, with her talk entitled Learning to Listen even, a patient-centered approach to Parkinson's care and research. But first, I wanted to tell you a little bit more about Camille. Camille is a professor of clinical neuroscience and honorary consultant neurologist. She's based at Newcastle University, having previously been at the University of Plymouth, where she led the clinical Parkinson service to 3 national awards. Her research is focused on disease modification and the use of digital health technologies for monitoring and personalised care for Parkinson's. Professor Carroll was the chief investigator of a multi-centre clinical trial of simvastatin as a disease-modifying agent in Parkinson's disease. She co-leads the Edmund J. Safra ACT PD initiative, developing a multi-arm, multi-stage trial platform for disease-modifying interventions in Parkinson's. She's developing digital tools to support patient self-management and digitally enabled care. She's the NIHR Clinical Research Network National Specialty Lead for Neurodegenerative Diseases, overseeing a clinical trial portfolio in neurodegenerative disorders, and leads the Remote Methods of Trial Delivery Working Group. In 2021, Camille was awarded by Cure Parkinson's and the Van Andel Institute the Tom Isaacs Award in memory of Cure Parkinson's late co-founder and president, to recognise her as a researcher who's shown significant impact on the lives of people living with Parkinson's and has involved people with Parkinson in a participatory way in her work. She's also the clinical co-director of the Parkinson's Excellence Network and has been widely recognised by both Parkinson's UK and so many others across the world for her patient-centred approach, broadening the opportunity for Parkinson's research and improving support for patient care and self-management. So when I said I was going to tell you a little about Camille, that was partly a lie. I've probably given you a little, but about an awful lot. Camille clearly shows a hugely impressive commitment to Parkinson's and people with the condition. And that makes it, I think, even more special. She joins us here this evening in person, and for many of you who are joining us remotely. Now, when I asked a colleague to reflect on Camille, she was described as a force of nature with fingers in all the pies. And when I asked someone with Parkinson's about Camille, they said this: if you are someone with Parkinson's on a project led by Camille, you are involved, your contribution is valued, and your skills are recognised and utilised. I can therefore think of no one better to give the Edinburgh Parkinson's Lecture this evening than Professor Camille Caroll. Thank you.
Thank you very much, James, for that very kind introduction. I'm here with my sticky pie fingers. I'm delighted to be here this evening with you in Edinburgh. It's a wonderful city. I was explaining to the taxi driver who brought me from the airport yesterday evening That for serendipitously, this is my third visit to Edinburgh, I think in about 6 weeks, having not been here for quite a few years, and I'm very much enjoying the experience. And also delighted to welcome not only the people in the hall, but also our online audience. I need to put my glasses on because I now can't see. So I'm going to talk to you this evening about a subject which is very dear to my heart, and that is patient-centeredness of care and research. And I'm going to take you essentially through my thinking journey, which has influenced my work over the last few years. What I'm going to talk about is only the tip of the iceberg, really, scratching the surface of this very important subject. So this is the structure of my talk. I'm going to talk about the definition of what we mean by person or patient-centered care, why it's important, how we can achieve it. And I'm going to talk through some examples of where this has been achieved very successfully within the UK, talk a bit about the challenges of what makes it difficult to achieve this, think about considerations in research, and then talk a bit about our own experience in trial design. So what is person-centered care? What is patient-centered care? What do we mean by those terms? And this has been defined by the Health Foundation in 2016. I'm just going to pick out a few of the key phrases there. And really what it means is professionals working collaboratively with people who use their services. So that those people, patients, have confidence to more effectively manage their health condition and to make informed decisions about their health condition. And importantly, of course, their care needs to be tailored to their individual needs. However, in order to achieve this, there's recognition that to do this really well, the way that we design our services needs to change. So it's not only about the interaction, the consultation being person-centered, but the whole service being person-centered. And only by having that complete collaboration can person-centered care really be developed. So to achieve this, people need to be involved in decisions about the design and development and delivery of their care services. So why is it important? Again, the Health Foundation has done a lot of work on this and collated evidence demonstrating that if people are involved in their care, if their care is person-centered, then that improves clinical outcomes. So, for example, people are less likely to use hospital emergency services, they're more likely to stick to their treatment plans, they are more likely to take their medicines correctly, and importantly, they're much more satisfied with the care that they receive. And interestingly, they are less likely to choose interventions or treatments which are invasive or more risky or more costly, and this sort of speaks to the realistic medicine programme here in Scotland. And as patient management and confidence and engagement with their care improves, then so does staff morale. And of course, that's very important also for healthcare organisations. So what is the context that we're in which we're trying to deliver and create person-centred care? And you will all know that we have an ageing population. The way that society is structured is changing. There is less in the way of nuclear family support for people as they get older. Families are dispersed geographically, sometimes across countries, sometimes across continents. The NHS and social care sector are under huge pressure. There are significant workforce challenges, including with the Parkinson's nurse profession, with quite a few professionals due to retire in the next 5 years, and the number of neurologists per capita in the UK is lower than in most other European countries. So this is a very challenging space in which to try to create and deliver person-centred care. And in Parkinson's, there are particular challenges. So the way that care is structured around standard outpatient clinic review, care is reactive rather than proactive. We know that care is generally focused on motor symptoms within the short consultation times that there are, and the panoply of non-motor symptoms, which is such a cause for reduced quality of life and discomfort for people with Parkinson's, is often not addressed. It can be very difficult for people with Parkinson's to access specialists because the Parkinson's specialists tend to be in neuroscience centres, and as a result, care generally isn't managed close to the home, and it's quite difficult to coordinate the multidisciplinary specialist team which is needed to really deliver effective care for Parkinson's. This is a snapshot of the UK at 2 time points. The one on the left is 2016, and the one on the right is 2039. And in 2016, this heat map in blue shows the population, with the darker blue squares reflecting a higher proportion of people over the age of 65. And you can see that this proportion is getting very much more markedly dark blue by 2039. And you can also see that people over the age of 65 tend to live in the peripheries of the country. They live in rural and coastal areas, not the big urban conurbations where neuroscience centres are located. And so this creates a challenge. But particularly for Parkinson's disease, this is the prevalence of Parkinson's by age. So this is the number of people with Parkinson's per 100,000 of the population for each different age decile. And 65 is around here, and you can see that the number of people with Parkinson's, more men than women, increases dramatically over the age of 65. So what we're looking at over the next 20 years is an increase, we know, of people with Parkinson's, primarily living in coastal and rural communities, and that's going to create healthcare challenges. In rural communities, if you're trying to access healthcare, public transport is poor. Your services are unlikely to be located close to where you live. You're likely to have connectivity issues with internet and mobile phone reception, and isolation and loneliness is a significant factor. And if you're a healthcare organisation trying to deliver healthcare into rural and coastal communities, you've also got some significant challenges. As a health and care system, you're getting less funding per resident within your community than other areas. You'll have significant recruitment of staff and retention of staff problems. Your staff will have to travel much bigger distances to get from their base to where the patients are, and of course that has associated costs. The geography of a region can really make it difficult to scale up a service if you do have a service that you want to scale up. And then if you've got expensive equipment or expensive expertise, again, that makes it difficult to access across a broad geography. So there are significant challenges here, and these have been discussed in the literature going back some years. So this was a piece written by Ray Dorsey a few years ago with Baz Bloom, thinking about how best to deliver Parkinson's care and how our current way that we deliver care really isn't meeting that need. So people with Parkinson's, as we've talked about, tend to live in suburban areas or rural areas. They might be less able to drive. Almost by definition, mobility is going to be limited to some extent. Sometimes they can have thinking and memory problems. The disease, of course, unfortunately is progressive and gets worse over time, and this also impacts on their care partners. And so to provide care for people with Parkinson's in our current system, what we do is we centre that care in an urban location in the middle of a city. You generally have to drive to get to that place. You then have to park your car, which can take you a while, and then you have to walk across a massive car park to get into the building, and then you have to navigate an unnavigatable complex warren of corridors to get to the right clinic room. And really, our care is almost inaccessible for the people who need it most. And of course, this is hugely stressful for not only for the person with Parkinson's, but also for their care partner. So as we think about our services and how we can make them better, we need to bear in mind that what we're talking about here is providing something for this single red dot. This is an image that you might have seen before, and I love this infographic. It's from Sarah Regara, who is living with Parkinson's. To manage her Parkinson's, Sarah spends 1 hour with her neurologist having supported care, and the other 8,500 hours in a year managing her own Parkinson's. So what we've talked about in terms of the challenges of providing service only is one tiny red dot in this sea of blue dots. So really we need to support people to self-manage their Parkinson's as well as provide the best effective red dot when they come and see us. So it is hugely challenging, and the future looks challenging. But fear not, because we know a chap who can keep a cool head in a crisis. And Professor Baz Bloom, who I'm sure will be well known to a lot of you, has written about this problem with potential solutions a lot over the last few years. And in this particular review, which is a personalised opinion piece, he is highlighting 5 core elements of personalised care management for people with Parkinson's, providing them with information, helping you navigate the care system, ensuring that care is coordinated, proactively monitoring people to pick up problems early so they can be nipped in the bud and don't escalate, and then monitoring the process of how all of that is delivered in order to make sure that care is effective. And he's taken this view further into what he's calling the quadruple aim of improving the patient experience for people with Parkinson's, improving the health of the populations where people with Parkinson's live, and also improving the well-being of staff who are providing the services, and overall, in a better managed system, reducing the healthcare costs. And this model of the quadruple aim, the challenges and potential solutions, has been taken forward brilliantly by Emily Henderson, whom some of you might know, Associate Professor in Bristol, who has designed an intervention called Prime Parkinson, which is a proactive and integrated management and empowerment network of care model for people with Parkinson's. And Emily is now trialling this, and she has successfully recruited the over 200 people with Parkinson's needed for the study, and it'll be really interesting to see the results of that. In her intervention, she is providing personalised care management, education and empowerment for people with Parkinson's, making sure that there's also education and empowerment for the health professionals looking after them, supported by technology which is patient and professional friendly. And by implementing these strategies through a range of activities, she's going to achieve the quadruple aim which Professor Bloom has talked about. So it is possible to have a service where care interactions and consultations are person-centred, where service design is person-centred, and people with Parkinson's are supported in their self-management. But I just want to take you back to something that I said before, that in order to achieve this, and it is possible, but in order to achieve it, we need to make sure that we involve people with Parkinson's in the design and the delivery of those care services. So how do we do that? There is statutory guidance from NHS England on how one can do this, and this was published in July last year. And in this infographic, it shows the different ways in which people can be engaged in their service design and delivery. So at one level, we can inform people, we can tell them what we're going to do and make sure they understand what the plan is. We can consult with people, we can ask them their opinion on what it is that we want to do. We can engage with them, we can listen to those thoughts and build that feedback into what we're creating. We can co-design with people, we can have a partnership where we involve people in the design and we have a shared production of the final approach. But in the sort of platinum level version of this, true co-production involves people not only being involved in the design of the service, but being involved in its delivery, its monitoring, its evaluation, and its leadership. And that's true co-production, and that's what we should be striving to do. And this is not a problem that's unique to Parkinson's, it's not a problem that's unique to the UK, this is a global problem. And the WHO, the World Health Organization, has also written about this. This is a document produced earlier this year, publishing a framework for how to meaningfully engage with patients, with people living with long-term conditions, including neurological conditions, including Parkinson's disease, on the best way to ensure that your care services meet your needs. And the best way to do that is by co-creation, actively engaging people, not only in the design of the service, but in its implementation, monitoring it, and evaluating it. And to do that meaningfully means having a relationship with our service users, patients, people with Parkinson's, which is equitable, which means breaking down the hierarchy which exists between healthcare professionals and patients. And to create what the Health Innovation Network here in South London call a partnership. So it really is an equitable relationship rather than the professionals being the expert and the patients responding to what they're hearing. So there are some examples of where this equitable relationship and partnership has worked really effectively within the UK, and I'm just going to show you some of those now. One is the work of Ramona Weil, who's based at UCL. And Ramona has worked with people with Parkinson's, their care partners and other stakeholders to create toolkits for people with Parkinson's also living with dementia. And you can imagine that this is a difficult subject to discuss, and to have people's viewpoints openly expressed in a shared and trusting environment is no mean feat. And Ramona achieved this by running workshops using tools such as art, collage, breaking down those hierarchies and making sure that people felt able to contribute in a way that their voices were going to be heard, they were going to be listened to, and there was trust. A very powerful set of resources that Ramona and the team have created. Another example is the work of Professor Annette Schrag, also at UCL. And Annette, again, has worked with people with Parkinson's in this NIHR-funded program to create another toolkit. This is a digital facilitated self-management toolkit for people with Parkinson's to support them in their self-management, and having the patient voice in the design and build of this has been really critical. Annette is also trialling this. The intervention is called Live Well with Parkinson's, and she also has recruited successfully 346 participants to the trial, which is ongoing. So in our work, we have also employed co-design methods to improve our service for people with Parkinson's. And we did this supported by Joe Langley, whom you can see a picture of there. Joe works at Sheffield Hallam University and is a clinical health design engineer. And we were working with Joe over a period of a few years, undertaking a series of workshops to lead us to where we are now. And our process for running those workshops and what we learned about how to maximise engagement is in the paper that I've got on the slide. But essentially what we did back in 2018 was run a series of 5 workshops, just exploring with people with Parkinson's from across Plymouth, Devon and Cornwall what they liked about their current service, what they didn't like, what was working well, what wasn't working well, what the challenges were, and then thrashing out with them potential solutions. And then we took the main front runners, if you like, in those solutions, or what it was that people really wanted, and formulated into what we've called our home-based care pathway, those 5 key elements. And we used another series of workshops to really co-design the resources and the service. And we're now in another stage of the process, project where we're trying to make as much of it digital as we can, as that will allow it to scale up and be available for more patients. And in this process, you can see we engaged very broadly with close to 30 people with Parkinson's and their care partners, multiple clinicians from different professions across our community, as well as managers and directorate staff within the hospital and the technology partners that we're liaising with. It's me. And you can see we use similar methods to the pictures that I showed you with Ramona. So we use Lego, we use plasticine, we use collage. And the value of using these sorts of tools in workshops like this is because they get rid of hierarchy. Everyone is equally bad at Lego. If you've got 30 seconds to build a Lego model of what you like about your care pathway or what you think works well, you're doing it almost at a spinal level, aren't you? There isn't much time to think. And so the Lego modelling was really very, very illuminating and of course great fun. We had great fun in these workshops. And what we learned about our service is going to be no surprise to any of you here, I'm sure. Waiting times can be long between appointments. People didn't like that. They wanted to see someone when they needed to see someone. They found it difficult to be seen in between times, of course. The clinic was far away from where they needed, where they lived, and particularly in Devon and Cornwall. Of course, there's no public transport really to speak of, so people having to drive down windy roads, difficult at night. And what people wanted was to understand how they can help themselves, and almost like a book of knowledge about Parkinson's that would give people knowledge and understanding that they could help themselves and manage their own symptoms. And out of this, we created what we have called home-based care, and it's got three main pillars to it, really. One is supported self-management, where people are provided with information to support management of their own symptoms. The ability to have a triggered review, so there's a single point of contact that people can get in touch with, which was another big ask, but of course people can still access their community services and Parkinson services if they need to, and we have remote monitoring, almost as safety netting in the background. And what we've produced with Joe, the picture doesn't really show it there, but we put a lot of effort into the look and the feel of the resources that people have, with the type of binding, the card. And we've created a suite of resources to help people understand and manage their Parkinson's with information. These cards here, which we call tracking cards. There's a patient passport, and we provide patients with training when they first go on the pathway, so they can understand how it works and what their care is going to look like. They get provided with resources, and then we try and facilitate triggered contacts when people get in touch. Ideally, we get back to people within 2 or 3 working days, and we can generally see them within 10 working days. And then as a sort of a safety net in the background, we use a device. This is the one that we happen to be using, which is the PKG watch, the Parkinson's kinetograph, and patients wear that once every 6 months and fill out some questionnaires, and that gives us an idea of what their Parkinson's is like, so that if we think they're running into trouble, then we can trigger a review. So the main objectives of the pathway are to empower patients with these resources to self-manage, to provide targeted reviews when patients say they need them, or when other folk think they might need them, such as the Parkinson's nurse, the GP or care partner, or we can pick up problems as they develop through our remote monitoring. And what we hope that we'll achieve through this is effective management. And we evaluated our pathway after about 100 patients had been on it for 6 months, and we showed that it was a good way of delivering care. It was feasible, and it was also effective. We conducted some interviews with people as they started the care pathway, people with Parkinson's and their care partners, and these are the terms, that the sort of themes that came out of that qualitative study. Patients and their care partners felt empowered. They felt they were able to proactively self-manage. They felt their care was given to them in a timely way, and they felt much more informed. So with this co-production process, we were able to develop a care pathway which met the aims that we know are important to Parkinson's. And importantly, moving forward, we have people with Parkinson's and care partners involved in running the service. They're part of our business team. We meet every month. And we also have patients and care partners involved in evaluating the service and overseeing the iterations. So that's what we've achieved in a sort of pen and paper format, if you like. It is possible to do this in a digital care pathway, and this is work that was done by Carolina van Heden in Sweden a few years ago now, using a very similar approach of workshops to understand from people with Parkinson's, what would you like from a digital care system? And actually very similar themes emerge. Patients want to be able to track their own Parkinson's. They want it visible to them, because of course you can do with a digital tool, for the information that they're getting to be supported by clinical decision support, so that their recommendations come to them for how to manage their care, and they want the ability to interact with professionals through email and other modalities. And this is pretty much the way that we are developing our home-based care pathway as a digital solution. So we're hoping that we'll be able to realise that for patients in the UK. So I've shown you how co-production can work. It can work for paper toolkits or online toolkits, or even a whole care service. But this is still tricky to do within our current healthcare context. And there are barriers and challenges to facilitating true co-production within the UK. And I think that's because within our healthcare system, there are some reinforcers of our current way of working. The drivers within the system, at least within England, are targets, outpatient targets, waiting time targets, waiting list targets. The measure of care quality delivered tends to be in the number of patient consultations, not the content of those consultations or the outcome for the patients. We don't have the systems within the hospital to manage care delivered in a different way. We have a standard outpatient booking system, and anything that is outside of that is actually difficult to organise. We don't have the ability to manage lots of data coming in from remote monitoring. We don't have the ability to easily set up triggered reviews. And of course, managing all the data requires a degree of digital literacy, not just for the staff, but also for patients. The culture within the organisation might not be used to embracing patients in that way, to have the patients or service users actually involved in designing, delivering, overseeing, leading a service. That's quite a step change in organisational culture. And of course, the people working within the organisations won't have experience of working in this way. It's not something that we're trained to do necessarily as healthcare professionals in our training. So it means that we can feel quite uncomfortable interacting with patients when we're used to a different way of working. And there has to be trust, of course, on both sides that people will be listened to and that hierarchy will be broken down. And these challenges to participatory healthcare are what the WHO is highlighting, because where hierarchies persist, inequity can thrive. And this is a problem within the UK, and it's also a problem globally. If you only involve people in the design of your services who are able to easily have a voice, then the disenfranchised and those without a voice will not have services designed for them, and that will perpetuate the inequalities and the inequity of health outcomes and care outcomes that we can see played out across the world. And this is a global problem, and that's why the WHO have addressed it. And we know that Parkinson's is a global problem. Parkinson's is the most rapidly increasing neurological condition worldwide, sufficiently worrisome for the WHO to produce a technical report on Parkinson's disease recently. So getting this right is important, not just for us in our communities, but for everyone living with Parkinson's. And when we think about those inequities that are built into the fabric of how we deliver care, it's important to think about research. What is it that guides our health and care decisions? It's research findings, it's evidence. We practice evidence-based practice. We deliver evidence-based medicine. And our decisions are very much grounded in the evidence that comes out of research. And we know that research participants are not diverse, research is not inclusive, and there are real risks associated with this. And I was very pleased to write this commentary with Professor Lynn Rochester, one of my colleagues at Newcastle, exploring the risks of research not being inclusive. Because what this means is that trial findings might not necessarily be relevant for some of the patients where those treatment decisions are going to be guided by those trial findings. And that's a big problem. And it's a big problem not only for Parkinson's, of course, but across the healthcare sector. And it's a real current problem. This is from this week's BMJ, looking at sex and gender bias in cardiovascular research. And historically, the big trials in cardiovascular research dating back to the 70s and 80s were solely, the trial participants were solely men. So a lot of our guidelines for treating heart attacks and strokes and cardiovascular disease comes from biased populations. And what the authors here have argued is that women have traditionally been underrepresented in cardiovascular research studies, leading to biased guidelines, under detection, under investigation, and under treatment. And you will know as well as I do that this is a very, again, hot and current topic in Parkinson's research, where the impact of Parkinson's on women particularly is understood. Sex and gender bias is an issue. Another issue, of course, is our understanding of Parkinson's in different communities, in different races, ethnicities, socioeconomic groups. And this has been highlighted by Bernadette Siddiqui and colleagues and Michael J. Fox in a paper here in 2021, where they wrote a call to action to promote diversity, equity and inclusion in Parkinson's research and care. And if we're going to make things better, we need to understand what the baseline is. And actually what they found was that most studies, at least then, hopefully better now, most studies don't report the race and ethnic mix of their study population or the socioeconomic group of the study population. So we don't understand at all the implications of the research in these different groups. And in those studies that did report those data, less than 10% of study participants are not white. So what does this mean? That means that we don't really understand for Parkinson's how there might be differences in the way that the disease presents or the way that it might change over time. We don't understand any potential differences in effectiveness or safety of the medications we're using. And importantly also, we don't understand the economic impact of Parkinson's in different communities and in different patient groups. And another underserved group, as well as ethnicity, socioeconomic factors, race and gender and sex, is age. You'll remember from that previous graph that I showed you that Parkinson's prevalence increases markedly over the age of 65. And most people with Parkinson's, most people living with Parkinson's, are over the age of 70 to 75. Most study populations are around the age of 60 to 65. People that take part in studies are generally 10 years younger than the average person with Parkinson's. So what do we know about the data from those younger trial populations? What's it telling us about those treatments? Do we really understand how Parkinson's affects the elderly, the very elderly, whether those treatments are effective or safe in the elderly or very elderly, and what about the economic impact of those treatments, or indeed Parkinson's, in the elderly? And if we're going to enable older people, and particularly the older, so over the age of 85, to take part in studies, we need to really think carefully about how we're designing our studies. And this is where a review that I wrote quite a few years ago now with John Zychek on this topic. This whole area of inclusivity in research is important not just for Parkinson's but across disease areas, and this is a project that I was involved with at NIHR looking at inclusivity in research. It was led by Professor Lynn Rochester and Professor Miles Witham in Newcastle, called Include, aiming to allow research to be more inclusive. And what the project highlighted was the multiple stages throughout the research journey where it's really important to get patient voice, to make sure that you're really enabling that research to be as accessible to as many communities as possible. From setting the research priorities to designing the question, what is the most important question, how are we going to design that study, how are we going to deliver the study, the evaluation of the findings of the study, and then the dissemination of the findings and making sure that it embeds into practice. At every stage, we need diverse patient voices. One of the first, or one of the main aims of that process, of course, is to make sure that a diverse range of people is recruited to studies, and then we will have a really good evidence base on which to base our clinical decisions. And this is something that NHS England is now taking very seriously, as in investing in, and they have a programme called Research Engagement and Network, or REN, development programme, specifically aiming to look for systematically embedded barriers to people taking part in research, because there are many throughout the healthcare system. And the ICSs referred to here are the integrated care systems, which is now the way that healthcare is structured in England. So this is something that's real. This is a real problem, and it is being addressed, aiming to improve inclusivity in research. The Include project had some really great outputs from it and continues to go forward. And this is one of the outputs that I just wanted to highlight, because it is another way of improving inclusivity in research. You'll remember that in the pandemic, there were a lot of trials of vaccines for COVID and also therapies for COVID for people who were seriously unwell in hospital, and then subsequently also in primary care. And it also became apparent, as you'll remember very early on, that sadly some groups in society were very much more vulnerable to the significant impacts from COVID with higher mortality than other groups, but those were the very groups who were less likely to be recruited into clinical trials. So as a research community, the NIHR thought about ways of improving addressing some of the reservations that communities might have about taking part in research, and produce a series of videos which are just super on the importance of research, addressing the reservations of each particular community. So making research accessible in that way is possible. Another way to make research accessible is to use our digital technologies. This allows us to talk across large distances and to deliver trials in a completely different way, so we can maybe offer research opportunity to somebody who's living on an island or in a geographically remote area. And so I've been very pleased to lead the Remote Methods of Trial Delivery project, again for the NIHR. And what this is trying to do is embed research practices for research designers, research delivery teams, research participants to think about how can we use these new technologies which are now available to us and of course expanded through COVID in order to deliver trials in a much more inclusive way, at least geographically more inclusive way. So for example, instead of coming to the clinic to have a face-to-face appointment, you could do that virtually through a video platform. Instead of going on site to have measurements taken, you can take a lot of measurements, like the blood pressure in this example here, by taking it at home. And rather than coming into clinic to fill out forms, you can do the questionnaires on an app. And all of this means that the trial is more deliverable. Another way that we can improve trials is to learn from the trials that we have already undertaken. And as James mentioned, I ran the PD-STAT study looking at simvastatin as a disease-modifying agent in Parkinson's, which was sadly a negative trial, but we learned a huge amount from it. And this is one of our learnings. We conducted a qualitative study embedded within the trial, and this was conducted by Tracy North, looking at the trial participant experience, what went well, what didn't go well. And we asked people with Parkinson's who were taking part in the study, those that were found to be ineligible, so when they came they wanted to take part but weren't able to, people who did take part but then withdrew, and we also spoke to care partners and members of the study delivery teams at different sites, just to get a full picture of what it is that makes a good research experience and what it is where there might be room for improvement. And what we found was that what really makes a good research experience, these are the main themes and sub-themes that came out of Tracy's work, was if people feel well informed about the study, well informed about their Parkinson's and the role of the study in their disease, and also really valued the relationship with the study teams at sites. And then things that were slightly more challenging were off-state assessments. We asked people to come in having not taken their medications the night before, and if any of you have done that, you'll know how challenging that can be. Another area that people found challenging was being kept, although it was an advantage when it happened well, it was a challenge when it didn't, was being kept well informed about the study. Some challenges related to the medications, either side effects or the size of the capsules, and then simple things that are easy to put right, but it's just a matter of getting them right, and that's making sure that we handle reimbursing patients' travel expenses, for example, in a timely way so that people aren't out of pocket, and making sure that visits are planned well in advance. All of this makes for a better trial experience. And this has been taken forward brilliantly by Emma Lane and Cheney Drew, working out of Bristol in the LEARN study, where they have again evaluated participant experience, this time from people taking part in the GDNF study for Parkinson's, to really understand what went well and where there's room for improvement. And they've taken this one step further by creating a suite of resources to support participants and researchers on enhancing the patient experience. So I'm just going to, in the last section of my talk, focus on our current trial endeavour, and how we've really tried to use all those co-production techniques and embedding the patient voice into our trial. So this is the Edmund J. Safra Accelerating Clinical Trials in Parkinson's Disease Initiative, or EJS-ACT-PD, and this is a project that I co-lead with Professor Tom Fultony and Professor Sonia Gandhi at UCL. It's a big collaborative project, and I've just put a photo there from our annual event last year. So I'll tell you a bit about the project because I think it's very exciting and I want it to be on your radar. So what we're creating is a transformational way of delivering trials for disease-modifying therapies in Parkinson's disease. So this is a standard trial, which you probably realise. You have your treatment here, treatment 1, and you're comparing it against placebo. You set up the study, people start taking the drug, trial ends, you evaluate your results, takes you maybe a year to do that, write the result, apply. If it was a positive trial, you then have to apply for more funding, set the whole thing up again, and then maybe, if you're lucky, within 5 years, you might be starting your next trial. That's very inefficient. Another way to do this is to run what's called a multi-arm, multi-stage trial, where you're basically concertinaing a lot of those things together. So rather than have just one treatment, you've got 3 treatments against a shared placebo arm. And rather than running a shorter study and then a longer study, you start your longer study right from the very beginning. So this is planned to be a longer study, but you still evaluate your data at various time points. And if these treatments don't work, those arms get dropped, and then you can add new arms in. So you've got a rolling platform that keeps going until there's no further need for a trial because we found a cure. That's the idea. And this has worked very well in cancer studies and has really driven the pace of change in treatment of cancer. And this is what we want to do for Parkinson's disease. And you probably realise that here in Edinburgh is the home of a very similar undertaking for motor neurone disease, MND SMART, and we've learnt a lot from the MND SMART team. So the way that we're doing this, and this is a huge piece of work to set up a trial like this, as you saw in that initial photo, the collaboration involved is huge. So we have set up 5 different working groups addressing different aspects of the trial design, the treatments that we're going to give, the outcome measures, how we're going to measure Parkinson's, do we have the infrastructure across the UK to deliver a trial of this size. We're going to be recruiting about 1,600 participants over 3 or 4 years. We obviously need funding, it has to be sustainable. And in each of these groups, there are chairs, but in each one we have people with Parkinson's or their care partners contributing in to every single decision that we have made over the last 2 years. And together, these PPIE members form the PPIE working group, supported by people from Parkinson's UK, Cure Parkinson's, and other stakeholders. The whole project is supported by a core team of research assistants and administrative support, and our fabulous project manager, Georgia, whom I'll come back to later. And the project is overseen on a sort of day-to-day basis by the core team, and also a steering group, which is made up of the chairs of each of these working groups. We're supported by a very helpful external advisory group chaired by Jessie Cederbaum. And we also, over the evolution of the project, have sought more PPI patient and care partner representation through a wider network and a community advisory panel, which I'll tell you about. So our PPI working group, our patient care partner involvement, is chaired by Kevin McFarthing, and Marie-Louise Zeisler is the research assistant who is supporting the work of the group. And the main remit of the group is to make sure that patients, people with Parkinson's, and care partners input into every single discussion, decision, and that the trial that we come up with, because this is going to be a big trial, it needs to be accessible, it needs to be acceptable, and it has to be feasible to deliver amongst the community of people with Parkinson's. And of course, the role of the group in our communications and strategy moving forward is going to be absolutely pivotal. So in order to support this level of engagement, we've had to create some processes. And at a very sort of simple and almost administrative level, we've just done things like make sure that the patient voice is the first agenda item on every single working group meeting agenda. After every working group meets, the chair has a debrief with the patient and care partner contributors and make sure that any misunderstandings are explored, that the PPI contributors understand the decisions and the way that they have been made in order to communicate that back to the broader PPIE group. And there's a standard reporting form paperwork to support that process. All of the working group decisions are then discussed in that way in the PPIE working group, and other questions might arise, and those are brought back to the next individual working group meeting. And in that way, there's a cyclical interaction with our whole PPI working group team. We've also put in other things, processes to support our PPIE contributors. So we run regular PPIE forums where an expert, a methodologist or a statistician might give a talk, a very informal talk about that aspect of trial design, what it means, breaking it down so that our PPI contributors feel they fully understand it and can meaningfully engage, and of course tell us what they think, which is really important. And then we run surveys after those sessions so they can be properly evaluated. Our contributors themselves have set up a WhatsApp group for themselves to create a safe space for sharing experiences, and they do that also with a PWP and carer only drop-in session, so they can think about what their priorities are and to make sure that those are brought to the rest of the team. And they're supported in all of this by the core team that I've described. So despite having all of this in place, we have 11 to 13 PPIE contributors. The number fluctuates a bit. It was still appreciated that there's still 11 or 13 PPI voices, and of course there are more voices to be brought into the conversation for a project of this ambition. And so we set up a wider PPIE network of maybe 30 people with Parkinson's, covering a broader range of geographies and demographics. And they can act as a reference point and do. So if there's a particular thorny issue or decision where we think we need to consult wider, then we can access our broader PPI network. And our PPIE panel has had impact on our trial decisions. So, for example, on eligibility criteria, people with Parkinson's, their care partners were very clear they wanted it to be as broad as possible, to this trial to be as accessible as possible for as many people with Parkinson's as we can. And that's what we've put in our eligibility criteria. They wanted the trial delivery to be supported at sites. So we are going to hopefully have core-funded research staff in 15 strategically located sites to support people with Parkinson's to take part in the study. And we've made it a hybrid study so that people can come for face-to-face visits if they want, or they can engage with the study remotely if they want, to really maximise the accessibility of it. We heard from our patient contributors that the treatments needed to be acceptable with as little impact as possible on daily lives, which of course means getting that pill count as low as we can, and that's what we've tried to do. And they also told us it's really important that people on placebo understand that placebo doesn't mean nothing. Placebo means standard medical care, plus all the advantages of taking part in a study, and we know that people who take part in studies have better healthcare outcomes than those that don't. We heard that the trial should be as short as possible, and for this undertaking, where we want to see whether something slows Parkinson's progression, we're going to have a 3-year trial. It could have been a 5-year trial, but we want to do it in 3. And we've done a lot of work, particularly led here by Christina, who's the research assistant supporting this working group, looking at the way we measure Parkinson's, because we wanted it, people with Parkinson's told us this should measure something that matters to patients in a way that's meaningful. So our initial outcome measure was going to be a movement-related outcome measure, and it's now covering both motor and non-motor symptoms. So the impact has been palpable on the design of our study. But I'm just going to reflect now on what I said before, the importance of having every voice in the room. And we felt that we didn't have every voice in the room. There are still significant underserved groups whose voice is not impacting on the design of our studies. And that is the voice of people from ethnic minorities, people living in more remote and rural locations, people from lower socioeconomic status, and older people with Parkinson's. And so in order to address this, we've set up a community advisory panel, and this has really been led by the brainchild of our very fabulous project manager, Georgia Mills. And this is a fantastic resource that Georgia has created with our community advisory panel members. So we have 10 members on our community advisory panel with a range of genders, a range of ethnicities, from a wide range of locations, not a Scottish island, but the Isle of Wight, so getting a bit of a remote participant, and with a range of health conditions. So when we advertised for members of our community advisory panel using our normal channels, we had responses from the normal community who would respond to that, and that wasn't the diverse voices that we wanted. So we had to broaden our reach, and our community advisory panel, not all of them live with Parkinson's, but they all live within these underserved communities with a different chronic healthcare condition, or have experience of caring for someone with a healthcare condition. And their experience and expertise has been invaluable, particularly as we move into the next phase of communicating about the trial and making sure that we recruit members of all of these communities into our trial. So, for example, having a multimedia approach to our information provision, whether it's through social media or video. How can we access people in their communities? What do we understand about outreach events and what events and support and infrastructure is within different communities? How can we make our materials accessible, for example, with language or subtitles or image explanations? And then targeting recruitment activity in particular bits of the country where we know people from particular communities might live or that we particularly want to engage with. And we can do this using infrastructure within NHS England. So having their thoughts, ideas and expertise in this area has been really invaluable. And we are to share the learning of this in the way that we've approached embedding the patient voice into our trial design to hopefully deliver a truly diverse and inclusive trial. We want to share that learning. So we've built into this an evaluation piece. And here are just some of the initial quotes that have come out of the evaluation. This is going to be a much broader study. But from the researcher perspective, what they really valued about having the patient voice in the room was when they were disagreed with, when their thoughts were challenged by people with Parkinson's, and that there was a very clear perspective of people with Parkinson's and care partners, which is not the same as the professional one, and it might be one that we haven't thought of as professionals. So really important to have that in the room. And again, the feeling of doing something meaningful is important to professionals as much as it is to our patient contributors. And they felt very pleased that they were involved in a big and groundbreaking endeavour, which this is. They really valued some of the infrastructure which we put in place to support them, such as the forums. And they felt that they were listened to and that their contributions were meaningful. And that's really, really important. So my final thought for the evening is this. So we learn a lot from our children. I've got 4, so that quadruples my learning opportunity. And this is my little guy. He's a lot bigger than this now. And one day he came home from school in his first year of school, so he's probably about 4. And I was telling him off for not listening to me. And he said, "Oh, I lost my listening skills. I need to find them." I said, "Oh, really?" He said, "Yes, I left them at school. They fell out of my mouth. I moved my tongue and they fell out." So I want to leave you with this thought, that we should not lose our listening skills when we open our mouths, and that when we listen, we make sure we listen and hear all the voices. And I just want to thank you for your attention. Thank the various organisations that I've worked with and collaborated with, and the funding bodies who've supported our work. And most importantly, I want to thank people with Parkinson's and their families across Devon and Cornwall, and the staff providing services that support their care. Thank you very much.
Grab a seat. So the only ground rule we normally have for the Q&A is that we don't take personal questions about your own medication, about your own situation in your own history. So that we get that quite often. So we don't. Camille's not going to entertain that type of question. The other thing is there's mics like this, sort of dotted around. There's one here. There's one a bit further up. Just press the button. If you press the button, you can't hear. But if you press it and it lights up, you can hear. Also, Michaela has a roaming mic, so if you have a question, please put your hand up. And also, Wang up there also has a roaming mic, so if you don't want to get up to press the button, please just put your hand up and we'll get a question for you. So I'm going to mix them between the online questions and the in-person questions, but if we could start with an in-person question, that would be brilliant. Does anyone have any questions? Oh, yeah, down here.
Is the study going to be carried out in Scotland as well?
So I didn't catch that.
Is your study going to be carried out in Scotland?
Yes.
Only in
Yes, it will.
Stirlingshire or all across?
Sorry.
Only in Stirlingshire or all over the country?
Oh, hopefully all over. So we are going to probably require in the region of 40 sites across the UK. And we have already started mapping out where those sites might be, speaking with interested clinicians in various centres. And as I mentioned, we are keen to get the research out, not just based in the centre, but more accessible. So almost like a hub and spoke model, if you like. So we'll have different tiers of centre so that the smaller hospitals can also take part.
Great. Any other questions from the crowd in person? Oh, there we go.
Hello, thank you very much for your talk. Apathy is quite a big thing with Parkinson's. Do you find you find it difficult to get people to contribute to your studies because of apathy?
I don't know is the honest answer, because of course I don't know who isn't turning up because of apathy. I think people with Parkinson's on the whole are very keen to participate. If that sits comfortably with them. So not everybody wants to take part in research, of course, and that's perfectly understandable. But if research is of interest, then generally people with Parkinson's are pretty well motivated to do so. But you're right, apathy is a problem, that sort of lack of motivation, and possibly fatigue might contribute to that. So it's a sort of a complex thing, apathy. I don't know that I've ever heard from a care partner, for example, or a family member, that they would like the person with Parkinson's to take part or think they ought to, but apathy has been a barrier.
Over there.
I'll just follow up on that point from Mark. Your multi-arm model is very complicated. Of course, there's a lot of scope for error there because of the complexity of the different layers of trials that are ongoing at the same time. But in addition, you're asking people to commit themselves for several years. Do you feel that that's a challenge for people with Parkinson's who want to commit themselves for 5 years, doing a placebo effect or something like that?
I'm just going to rephrase your question because I was getting quite a lot of feedback on the mic and I just want to make sure I've understood it properly. So you were asking about the duration of the trial and what we feel about having people on placebo for that duration. Is that what you were asking? Sorry, it's not here.
Sorry about that. That was probably my fault. No, what I was saying was the commitment for many years to one particular trial.
The commitment?
Do you feel that people with Parkinson's will give a commitment for many years?
Yeah, no, I think people will. So we a lot of trials, of course, are short. If it's a trial for a dyskinesia agent, for example, those sorts of trials might be done in 3 months. So that's pretty short. But a lot of disease-modifying trials that we're talking about are 2 years plus. So our statin trial was 2 years. The exenatide trial, Tom Pulteney's exenatide trial, is also 2 years. This will be 3 years, so it will be a bit longer. But I think if people are committed to the endeavour, and they generally are by the time they sign up because they've learnt about it and it's something that they want to commit to, then I think that's fine. The impatience, if you like, wasn't so much about the commitment. It was to do with the duration before an answer will be known. And of course, what people with Parkinson's want is an answer that if that drug isn't working, then let's know that quickly so we can try something else. Equally, if it is working, we want to know that quickly so we can have it prescribed for us. So it's for that reason that people with Parkinson's in our groups wanted to have the trial as short as possible, because they didn't want to be waiting more than was needed for an answer, rather than questioning the commitment.
Great, thank you. So we've actually have 54 questions online. A fair number are medication related that are not quite directed towards the talk, but here's one that is from Anne that's quite popular. How can we begin to develop cooperation between healthcare professionals around an individual with PD and one other chronic condition, such as Parkinson's and diabetes? This would help better self-management, improve outcomes, and ultimately reduce costs.
Yes.
So how can you foster that cooperation between these different types of healthcare professionals?
Oh, yes, that's an excellent question.
Thank you, Anne.
And tricky, and I think informatics will help here. So there have been studies looking at this sort of problem, not necessarily through that lens, but that sort of problem. How can we get different professionals working in different organisations, looking after the same patient, to know what each other is doing in a way that is helpful? And a good informatics system can really provide that support. And that, whoops, I keep hitting this thing, stand further back. There are systems within the UK that could possibly help. So I think the Patients Knows Best app does something similar, because it allows all of those different pathways to be visible to all the different clinical groups. So if somebody had Parkinson's and I logged on and they also had diabetes, I could see what their diabetes care plan was. So it's that sort of thing. The role of the general practitioner, of course, is critical, and to have care coordinators who interact with each other, so that if there were a care coordinator for Parkinson's, and for most people, of course, that would be your community Parkinson's nurse, that if you were also under the care of another chronic condition team, diabetes, your Parkinson's nurse could speak to the diabetes nurse. So human interaction, technology-enabled interaction, information visible when needed, all of those sorts of things. But it's really difficult. We can't even do it for one disease. I can't think how we can do it well across diseases.
I'm going to ask another popular question. I think you've answered in your talk, but it's good to really hear your answer again. How do care partners and people with Parkinson's get their voices heard when clinic appointments are only 15 minutes, guided by clinicians who seem focused on time?
It's impossible, in truth. So, I mean, you can use various tools, and some clinics will. Not so much for the care partner view, actually, in terms of what I've seen implemented, but in order to get more of your own perspective as someone with Parkinson's into that clinic consultation, and there is a limit to what you can say in 15 minutes, so you can do information gathering ahead of time by filling out questionnaires. So a lot of clinics, for example, would use the NMSQ, the non-motor symptom questionnaire, in the waiting room or ahead of the clinic, so that when you walk into the room, you're presenting the clinician with your highlighted list of symptoms, and you can choose your top 3. And some clinicians will do this. They will ask, what are your top 3 things that you want to discuss in this 15 minutes? And that can include the care partner perspective. But it is very, very tricky.
Thank you. Any more questions from the floor? Oh, James.
Hi, it was more about the data, the kind of first half of your presentation. One of the things about some of those models you were suggesting is the wealth of information that could be produced as a result. So if someone was monitoring their blood pressure every day, and also whether the NHS itself is ready for that wealth of data that might come back from individuals reporting on their general state of health and well-being, both from a patient and person perspective and from the NHS perspective. Do you think, are we set for success? Are we ready for that kind of transformation to happen?
I don't think we're ready for it now, but that is where we need to get to. And there are disease areas where this works. So, for example, some cardiac conditions where people might have implanted devices which are recording rhythm disturbances or pacemakers that are sending data back to cardiac teams. So that there are systems where this does work. We need to learn from those other systems. We need to be thinking across diseases, what has worked here in that sector, which we can then implement for Parkinson's. But you're right, the benefit isn't going to be in the way that we view data now. The benefit is going to be in the algorithms, the learning, machine learning, artificial intelligence tools, looking at patterns in the data, so that we'll be able to use the data coming in to personalise someone's care and also predict where their risk is. So if someone has a pattern of gait or a pattern of something else that's coming from a wearable that makes might facilitate a prediction that they are likely to fall, for example, in the next 6 months. And that will allow targeted intervention of physiotherapy before that first fall. That's the sort of step change in care that can be facilitated by analysing lots of data and the patterns within those data. But you're right, in terms of individually using data to support a single person's care episode, that is quite cumbersome, and we don't have the system processes routinely available to do that.
Great. Thank you. David.
Hi Camille, thanks very much for your talk. It's David Breen. Can I ask you just a quick thing? Firstly, are there any drugs or therapies that you think will be not appropriate for a platform trial, either because they're trying to deal with a particular subtype of Parkinson's or some other reason? And secondly, in your home-based care, how important do you think home wearables will be versus other patient-reported outcome measures? And I'm thinking particularly for people don't notice or think they are. So how much will it replace versus supplement clinical decision making?
Yeah, it supplements, it doesn't replace. And you're right. And just that example you gave, you're absolutely right. So I've triggered reviews with patients where I've seen what I have thought have been quite significant motor fluctuations on the wearable. And it doesn't matter how I've asked the question, and I've asked it lots of different ways, they're not perceiving any fluctuations at all. And of course, that's fine. And that's useful learning for me to understand. No test is 100% accurate, sensitive and specific. So there will always be inaccuracies or differences in perception. And what matters, of course, is what the patient, the person with Parkinson's is experiencing themselves and what their perception is of their life. I think there is room for more home sensors and to enrich the data set in the utopia world where data can be handled at scale, not currently. And the reason I say that is because at the moment we've only got sensors primarily geared around motor function, accelerometers. There are studies ongoing to try and get a handle on some of those really important and impactful non-motor symptoms. An obvious one would be sleep, which of course you can address with a wearable as well, but a sleep mat, for example, that you put on your mattress might give really good information about sleep quality, and we know that's really impactful in Parkinson's. Idea Fast is a big EU-funded project being run out of Newcastle as well, looking at fatigue and other couple of other non-motor symptoms, not only in Parkinson's but also in inflammatory diseases, evaluating the use of digital technologies in picking up those symptoms. And then you can use quite sophisticated home sensor technologies with cameras or detectors around the home, sensors around the home, to look at pattern of room use, for example, or how long it takes someone to traverse a room or go through a doorway. So you can start to get really quite nuanced information using a suite of sensors. How much that will capture the non-motor symptoms, I think, there might always be a place for self-reported measures. And then what we want to reach is the point by which everyone understands the limitations of the measurement system. The person using the system, the person with Parkinson's, but also the clinician, because there will always be, at some level, a disconnect between what you're measuring and what the patient is experiencing and the person with Parkinson's is experiencing. A bit like imaging. You know, you pick up things on imaging that actually aren't impacting someone at all, and it's understanding where those points are. First question, I've forgotten already. Interventions that might not be suitable for a platform trial. So we thought about this, and the reasons why something might not be suitable for a platform trial approach. You mentioned particularly subgroups. So at the moment, other than possibly genetically targeted therapies, so if something you thought was only going to work on LRRK2, for example, or GBA, you might have a reason for only recruiting those patients into that study, or people with those mutations into that study. However, we think that the downstream effects of those mutations, both LRRK2 affecting mitochondrial function and GBA mutations, are of relevance to idiopathic Parkinson's as well as that specific genetic subtype. So by saying you're only going to test your therapy in people with that mutation, for example, you might be missing a benefit in people who don't have that mutation. So until you've got evidence that it works in these folk but not those folk, there is no reason to subtype. So the way that we're thinking about this is that we would actually, at least currently, test most therapeutics across the spectrum of people with Parkinson's, and then do a planned analysis of subgroups. And then if it turned out that there was a much stronger signal in the subgroup, that would then be evidence to base a further study enriched or targeted only for those people. The other therapies that might not be suitable for this approach are those that have a very different mode of delivery. So at the moment, we're testing medications which are taken by tablet twice a day or 3 times a day. And of course, if one of the therapies is an injectable or an intravenous infusion once a month, then you can't do a placebo. The shared placebo arm is going to be different. Those people on that therapy, although there'll still be some people on the placebo of that, the dummy drug version of that, that's going to be very different from a tablet. And we don't know whether that will influence the analysis of the study, but that's a tricky statistical problem which the very clever statisticians are able to grapple with, I'm sure.
I guess a cell replacement trial as well, a surgical trial probably wouldn't fit in this multi-arm.
No, exactly.
I'm going to ask the most popular question online, although it is drug-related. Might be good to get a second opinion as well. But here it goes. True or false? The more levodopa you use in the early years of Parkinson's, the sooner you'll have to look for alternatives in later years as the medication has lost its effectiveness.
False.
False. Okay. Clear answer. Good. Good. Okay.
I can expand if wanted.
Yeah. Yeah, I think I remember hearing about the triplication synuclein patients in Iowa. As soon as they started getting levodopa into that family, just the quality of life, the longevity of the patients all increased. So, yeah. I think the answer is false.
It is false. So there have been studies looking at the effectiveness of levodopa in people with Parkinson's at different disease durations, and levodopa itself continues to be effective. If you measure people, excuse me, you realise in Parkinson's studies we often use a scale called the UPDRS, the Unified Parkinson's Disease Rating Scale, where we ask people to do various movements, this sort of thing, and rate what their Parkinson's is like. And we can do that when people are off their medication, give people levodopa and do it again on medication, and you can see an improvement in tapping speed and the extent to which the hand is opened and that sort of thing. And there have been studies that have shown that even when people have got quite marked Parkinson's or Parkinson's that's been with them for some years, that levodopa will continue to be of benefit for their movements. That doesn't mean that it continues to have the same impact on their activities of daily living or quality of life, because other things are happening, unfortunately, in Parkinson's. It isn't just a dopamine disease. The disease process is also affecting other chemical transmitter systems, acetylcholine, serotonin, noradrenaline, and the levodopa will not be impacting those symptoms. And the other problem, of course, is that we're getting older. So as the disease progresses, the person with Parkinson's is also getting older, and unfortunately things change with age, and the body isn't as robust. We're more vulnerable to things going awry. The ability to bounce back isn't as good, and so all of these things mean that the Parkinson's will be getting worse despite a good dose of levodopa or an effective dose of levodopa. How much you use in early disease is sort of irrelevant, other than the caveat of one should be judicious with the dosing, try and avoid big peaks and troughs, because we know that that's not good for the development of motor fluctuations. But you're absolutely right. Studies have shown treatment with levodopa in early disease is the best way to get good control of symptoms and maintain quality of life for as long as possible.
Clear answer, thank you. So this next one has been represented a number of times, but I'll ask this one. How do we ensure that the perspective of disengaged or more isolated people with Parkinson's are represented in these collaborative design of care when a lot of the older patients are not engaged with digital health, don't understand e-health, and don't even have access to the internet?
Yeah, so I mean, you're absolutely right. So a care pathway for folk in that position would not be a digitally enabled care pathway, because it isn't going to meet their needs. So it sort of speaks to the underlying premise that in order to make sure that as a healthcare provider, you're providing a service that meets the needs of your community, you need to understand who the community are and what their needs are. And unless you include as many people as possible from different diverse sectors of your community that you're serving, you won't understand what their needs are. How to engage people, of course, is very tricky. And what we've learned from research work is you can't expect people to come to you. That's a very optimistic way of working. You need to go out to where people are. The community that comes to mind in that question for me is the care home community. So people living in residential care are often not even so visible in clinics any longer, because they have a challenge to get to clinics if they can't drive, dependent on being brought by care home staff, and are generally looked after by community teams. So the extent to which there's a secondary care provider in hospitals, we're really meeting the needs for specialist input into care home residents is questionable. And until we really achieve the integration, which I guess the ICSs are set up to try and achieve, the integration between our specialist medical services and people's social care needs and where they're based, we won't really address that problem.
Great, thank you. 2 more questions, Tina. 2 more, okay. I have one online, but let's do it in person. Yeah, sorry, I'm not seeing everyone. Yeah, please.
A great talk, thank you. It sounds like everything is okay?
Yeah.
It sounds like designing the patient experience is a crucial part of the trial design for you. And can you share a little bit more what patient involvement group mentioned as an added value for them in terms of participation in the research? Thanks.
Yeah, thank you. So I just showed a few of the quotes at the end there about what they felt was important for them. And it's the drivers to why people take part in research at all. There's a real sense of altruism, to be part of something bigger, to be using their misfortune, I guess, at having a condition like Parkinson's for the greater good, and making sure that something good comes of it, if not for them personally, then for other people with Parkinson's in the future. And being part of an endeavour like this has enabled those feelings. Realising that they're impacting and feeling listened to has helped them feel more empowered in their participation in the project. So I think it's a sense of self-worth. It's been really nice working with the group over the two and a half years, and watching them grow in their confidence, being advocates and ambassadors, and realising how important it is to have their voices in the room. I don't know how to phrase it any better than that. They have all valued it. I think when this project ends next year, I think we will certainly miss the contribution, and we are thinking about how we can harness the power of what we've got, really, to continue to support the study moving forward with different roles for our contributors.
Great, thank you. This is a theme that's been coming through the questions. I'll just read one of them, but there's a number of people asking similar questions. How can we get this care model implemented across the UK?
Yeah, so it has to be scalable, that's the thing. So The WHO document is actually pretty interesting read, although it's obviously aimed at global, the lessons are for global impact. The content is equally applicable to regions. So if you're going to do something like this, it has to be adequately resourced, there has to be capacity, and this is what we don't have in the NHS at the moment. All the social care sector is resource, headspace, capacity, funding to support these sorts of undertakings. Our particular care pathway is not scalable. It's very administratively heavy because we're relying on questionnaires, it's not digital. And the administrative team at Derriford Hospital in Plymouth will, I'm sure, echo that thought. And they are superb in the support they're providing for the pathway, but it is not scalable. So we have to digitise it to make it scalable. And then when we've got something that is scalable, then we can spread it out into different locations. It isn't going to be that easy to do that either. This was designed in Devon and Cornwall. Devon and Cornwall are not the most diverse bits of the country, and we don't know whether what we've created will land well in East London or Leicester or Bradford or other communities where there is more diversity, or meet the needs of communities who are even more geographically dispersed, such as parts of Scotland. So we need to understand whether this is fit for purpose to translate or how it needs to be adapted in order to meet the needs of the community there. So there is more work to do for sure.
Great, thank you. Thank you very much, and thank you for all the questions online. We'll give a round of applause for. Thank you.
I didn't brave this. So I have got one more thing to say, if I may. This is, I promised I would waive it, but my planted question didn't materialise. So I forgot all about it. So this is an opportunity for people with Parkinson's. If you're interested in taking part in research in Scotland, it's a Scotland-only opportunity, then please do register for or sign up to the register for people with neurodegenerative disease, so that a research opportunity can be made available to you if there is one there that you might be interested to take part in. So these leaflets were outside. I'm sure that they are no longer because it might have been cleared away, but please do have a look for it. It's called the Neuroprogressive and Dementia Register. Thank you.
Thanks, Camille. We have plugged that to the Neuroprogressive and Dementia Network at the Edinburgh branch. Time for some concluding remarks. I'd now like to ask Dr. Alison Williams to make them. She's a person with Parkinson's, but she's also honorary professor at Queen Margaret University in Edinburgh. Alison.
Professor Carroll, thank you. And paradoxically, after listening to your inspiring and thought-provoking and deeply hopeful lecture, I now feel listened to. And I feel that my voice and that all the voices of the Parkinson's community are heard, and that our voices matter, and that we're not doomed. And your exceptional work is showing us what can happen when the medical focus shifts, when we're no longer just a bit part in the medical story, but instead we're at the center of a rich conversation of collaboration and voice. Voice. One of my earliest symptoms, pre-diagnosis, was being ignored. No one paid any attention to what I said. And I even went to a group therapy session about it. But it was just that my Parkinson's voice was so low that nobody knew I was speaking. I had lost my voice. So how good it is to hear you reaffirm that post-diagnosis, we don't stop being articulate, feeling, thinking human beings. That a Parkinson's diagnosis is not a long drink from the waters of forgetting. I would have said the classical waters of Lethe, but this is Edinburgh and it might have been misunderstood. and how empowering to hear you affirm that we bring our new knowledge, our lived experience to the ongoing conversation, and that lived experience matters. And you've shown us how our voices matter clinically, how self-management and digital tools can bring improved health, and that our voices matter psychologically, impacting our own and our care partners' mental health and supporting our health professionals' emotional health. And moving into research, you're showing how our voices and the PPI engagement matters deeply for the inclusivity and the success of that research. Joy Milne has pointed out that the letters of listen also spell silent, and that until we silence the assumptions and preconceptions in our own minds, we can't hear what is actually being said rather than what we want to hear. And you've shown us what's possible when the hierarchy flattens, when everyone listens, when expertise is equally valued, learned and lived experience working together. As Baz Bloom said, the patient and the doctor are the expert. So, Professor Carroll, thank you again for reaffirming that we all, as people living with Parkinson's and as care partners, we all have a voice. And that voice, in all its diversity, is worth listening to. That voice matters. So, thank you.
So it's time for some thanks. I asked Alison to do the vote to make the concluding remarks this year because she'd done it last year. And you can see why I asked her again this year. Thank you, Alison. I'm grateful to Thilo for juggling the online and the live questions in a way that I would be physically incapable of doing. I'm grateful to James and the Parkinson's UK staff for all their help tonight. And it's without their network, I wouldn't be able to get 300 bums on seats at the Royal College of Physicians of Edinburgh and 800 people watching online. I rely on their networks to get a lot of the people in. I'm also grateful to members of the Edinburgh branch for their support, and to the team, the Royal College of Physicians of Edinburgh team, for putting on the show for us today. Thanks to Professor Carroll for showing us the future of Parkinson's care and research, and I just hope that a number of us are around long enough to see that future. Could I have the slide, please? So, I hope everyone's enjoyed the lecture. We're after money. If you'd like to support the research effort of Parkinson's UK to find better treatments and even a cure for Parkinson's, then there'll be a collection as you leave the foyer area. Casual card accepted. You can also donate by going to the Just Giving link, which is shown here. And if you're watching online, you could also donate via the Just Giving link, which is visible at the top of the web page. But most of all, I'd like to thank everyone for watching, both turning out to the Royal College. The weather forecast wasn't quite as good as I'd predicted, but it wasn't too bad. And to everyone who's watched online, thank you, and we look forward to welcoming you again for a future Edinburgh Parkinson's lecture. Bye-bye.